Yeah.
Good. Right, so we're going to start now. Haitham has agreed kindly to do a presentation in complication of sinusitis. So I'm going to start sharing now, and we're going to record everything as well. So. Can you see the screen?
Yeah, can see the screen.
Perfect, thank you. So I'll just pass you with Haitham.
Thank you. Thank you. Okay, so thank you for everyone who's attending today. I think this is one of the our series for our lectures on our ENT teaching in departments. It was supposed to be about complications of sinusitis only, but I prefer just to go through the sinusitis in general and managing it in order to be understanding the reason behind the pathology, the physiology, and what are we aiming to do with the patient who is presenting to us in A&E, and how can we escalate the symptoms, discuss with seniors, offer investigations, manage properly depending on where's the patient on his journey to be treated properly for his sinusitis, and if it is complicated, what can we do? Definition of the sinusitis, it's a common condition which is happening all over the world actually, and it is causing significant burden on the society for healthcare consumption and productivity loss. That's because of the usage of antibiotics, which is one of the most common reasons of prescribing from GPs, NAs, and definitely ENT surgeons. And it is one of the main reasons behind the resistance to antibiotics. Maybe that's because of the commensals in our nasal cavity and the inappropriate antibiotic prescriptions all over the world if we are not going to be stuck into the guidelines. And there is a big difference between chronic sinusitis and acute rhinosinusitis, with the chronic rhinosinusitis being affecting 5 to 12% of the general population, which is quite a good number. And when we are defining the rhinosinusitis in adults, we have to keep in mind this exact definition, which is the inflammation of the nose and paranasal sinuses, with the three specific symptoms of blockage, obstruction, congestion, or nasal discharge. And we will be asking about the nasal drip, if it is anteriorly or posteriorly, if the patient is spitting or not, if there is any facial pain or pressure, and the reduction in smelling as for being hyposmic or anosmic. And we can then go through the examination with endoscopy in order to see any polyps or any discharge mucopurulent coming from the osteomeatal complexes, the sinuses as maxillary, ethmoid, and frontal, or if there is only edema in the turbinates, which is one of the main signs as well to help us in diagnosing sinusitis. We are commonly in examining the nose in order to look for polyps, but sometimes all what we can see is edema, and that doesn't mean that there is not something behind the mucosa. It could be still some polyps, it could be a fungal ball, and edema on its own is one of the good signs to see in an endoscopy. And when we are offering CT sinuses, we will be seeing the blockage in the osteomeatal complexes and the mucosal thickening. So it is basically about asking about those three symptoms and looking for those three signs and asking for a CT scan in order to make an appropriate definition and a diagnosis of chronic sinusitis. This is just a slide to show us roughly what is the pathophysiology between those cofactors in order to cause some sinusitis, and I brought it from Scott Brown Essential. It is based on some fungal antigens, eosinophilic mucus, biofilm of the bacteria or anything has been impacted in the nose as a foreign body, staphylococcal enterococcus, which is one of the most common bacteria causing rhinosinusitis, and that would be affecting our antibiotic prescription as well. Some osteotic bone or asthmatic patients, aspirin sensitivity, or a polyp which is blocking the complex. So all of these, all in all, will just be working together simultaneously in order to cause the pathophysiology behind the chronic rhinosinusitis. And that's how we are going to target each bit of it in our management. Is there relation between bacteria and nasal polyps? Yes, there is. And the most common bacteria is the Staph aureus enterotoxin, which stimulates the T cells and cause cytokine response and eosinophilic inflammation, forming IgE antibodies. So whenever we are asking for IgE as a part of allergic rhinitis, this could mean that the patient is allergic to this enterotoxin of Staph aureus. And that's when the antibiotics will help with asthmatic or allergic nasal polyps as well. There is a good relationship and co-diagnosis between asthma and polyps, as 25% of the patients with asthma will be having polyps, and 45% of the patients who develop asthma within 10 years of their whole disease, they will progress with nasal polyps. So it's quite important to look into the nasal cavity, especially in a patient who is asthmatic, in order to expect some nasal polyps, as there is quite a good relation between both diseases. One of the other types of nasal respiratory disease is the non-steroidal anti-inflammatory, which we call it NERD, and it is a chronic eosinophilic inflammation of the respiratory mucosa in asthmatic patients. And that's when we describe it as a Sanders triad. It is only 0.9% of the population, but again, it is related to asthmatic patients, and here we added only the aspirin sensitivity. So whenever we're asking for the triad, it will be the allergy, the asthma, and the aspirin hypersensitivity. The problem with that condition is that there is 90% recurrence in 5 years, even if we treated the patient surgically. So that's how we can tell the patient, okay, so we have done our best to control your nasal polyps. We have given you everything in our box, but you're still expecting to have some recurrent polyps, even if we treated you surgically, giving you high dose of antibiotics and steroids. That's based on the condition of being allergic to aspirin. What about allergic fungal rhinosinusitis? This is one of the most common causes of allergic acute fungal sinusitis or a chronic fungal sinusitis. And this criteria would help us in asking the patient about specific symptoms and guiding us through our diagnosing this type of patients. So, for example, if we know that the patient is having an IgE fungal stain in his mucin, this will help us in diagnosing fungal sinusitis. If the patient is having a positive stain on his surgical specimen of polyps after FES, and that's actually what pathologists do. If he's having eosinophilic mucin, and that's a biochemical examination, definitely nasal polyps is one of the starting signs to be seen in the endoscopy and characteristic CT findings. So all in all, these 5 symptoms or signs will be helping in diagnosing the allergic fungal sinusitis. However, recently, some studies describe that in order for a patient to have all 5 signs, it would take many years, and the patient would only be presenting with 2 or 3 of them. So this is not like a must sign to look for, it's just like a guidance to help you in predicting allergic fungal rhinosinusitis. And that's how it could be presented in a CT scan. You can see here how the bulging on the sinuses, the ethmoids, there is some hyperintensity here with some protein and mucinous material. And on the endoscopy, there is this mycetoma, or what we can call like green discharge, which is coming out of the maxillary sinus. And the MRI scan as well is showing like this enhancing, expanding lesion, which sometimes is deceiving for radiologists, and we can consider having a cancer in this type of imaging. But considering fungal sinusitis as a long-standing problem and an indolent symptom is quite important. That's how it looks like intraoperatively. If you are taking some polyps out, you will find that it's not like the pale mucus or the pale mucosa. It is something which is discolored, having some green and brown colors in it. Okay, so if we are asking about symptoms, is the patient an acute presenter or a chronic? It's based on the cut line of 12 weeks. If we're talking about less than 12 weeks, it will be acute. If it is more than 12 weeks, it will be a recurrent. If it is a recurrent acute rhinosinusitis, so it is defined as being having more than 4 episodes per year, with symptom-free intervals, which is the most common, I assume, type of patients which we are seeing in our rhinology clinics. In your clinic or even in A&E, if we are examining the patient, just to keep in mind, if we can put those scores in our letter, that would be really important and helping in following up the patients. So this Lund Kennedy, again, this table is from Scott Brown, and it is found in this rhinology paper, Otology, Rhinology, and Laryngology one, published in 1995. What is good in this scoring is that it will help us in understanding how is the patient being improving on our treatment, if he's having nasal steroids, and if he's having antibiotics. Where are we from the start? Have the polyps improved? Is the edema getting less? Is the discharge being treated? Is the scarring of the surgery still there, or is there any crusting? So when we are scoping the patient in clinic with polyps, we were gonna describe the polyps, where is it, grading it from 0 to 2, and the edema, discharge, scarring, and crusting, and we will give it as a maximum. I think it will be 2 times 5, it will be a 10 as a maximum score. And the Lund-Mackay is the one for radiology. As the slides, for example, we have seen here, this CT scan, we can use the scoring in order to predict and describe where is the patient now, even before treatment. So we are gonna describe the maxillary sinus on its own, the ethmoids, the sphenoids, and give it a score from 2 to 0 based on the opacification. So I would go for this one, for example. This is a definite complete opacification of the ethmoids, maxillary, and the nasal cavity. So this is at least 6 on grading. This is the European paper of sinusitis, and this is the guidelines for classifying and treating sinusitis. And this is just like a general theme of chronic rhinosinusitis. How would we think of it? Is it primary? As there is no specific etiology we can describe in this type of patients, but still we can say that it is localized or diffuse, and the types would be type 2 or non-type 2, depending on is it an allergic fungal or an isolated sinusitis, or a chronic with polyps, or non-eosinophilic chronic rhinosinusitis, or if it is secondary to something which we know about. For example, if there is a fungal ball in the sinuses, if there is a teeth problem causing it, if the patient is having ciliary dyskinesia or cystic fibrosis, if there is a granulation and a granulomatous disease behind the polyps. So all of these will be causing some secondary rhinosinusitis, and that will help us in managing those factors first before controlling the symptoms. And when we go through the EPOS guidelines, this is a nice algorithm. If we have it just in mind to understand where is the patient who is presenting to us. If you are having a phone call from a GP or the A&E doctors who are referring the patient with complicated sinusitis or just an unresolved sinusitis. So just keep in mind, where is this patient, or where should he be treated? Is it like a self-care pharmacy, or with a GP, or through ourselves? It depends on the days of symptoms. Is it less than 10 days or more? Is the patient having any sign of the acute bacterial rhinosinusitis, as for having fever above 38 Celsius, double sickening, which is quite important if the patient is reporting that he has been improving on treatment, and then he came back with worsening symptoms. This is called double sickening. If there is unilateral disease or severe pain and raised ESR or CRP. So in those terms, we are gonna expect acute bacterial rhinosinusitis. However, this doesn't mean that we are gonna rush for antibiotics. No, we are still using some self-care treatment, which is this nasal decongestants, less than 10 days, some herbal medicine. Those, by the way, on the guidelines, it's not conclusive that it will help, but at least they are helping with the symptoms of the patients with avoiding antibiotics. When are we going to think of antibiotics? If the patient is worsening his symptoms more than 10 days, or it has increased after 10 days, after 5 days of having the symptomatic treatment. And in that term, once we give the patient the antibiotics, we are gonna decide if the patient is gonna improve, or are we considering referral to our team, which is why we would be asking the referral. Has the patient had any antibiotics, and for how long? Which course? Has it passed the 10 days or not? How is the patient mentioning his symptoms. Is it getting better, worse, if it is still the same? And for sure, keeping in mind the alarming symptoms of any rhinology sinusitis, which is the preorbital edema, displaced globe, double vision, ophthalmoplegia, and reduced acuity, severe headache, signs of sepsis, or central causes. So these things you have to ask on phone. If the patient is having one of these or more, please refer him straight away. This is the same algorithm, but in a different way. And for the NICE guidelines, when we are asking about the antibiotics prescribed, we hope that the patient is having his first choice first, which is phenoxymethyl-penicillin. If it is not, it will be a Comox if the patient is still feeling unwell or the symptoms have developed after being on phenoxymethyl-penicillin. If the patient is allergic, he will be on clarithromycin or doxycycline only for 5 days. Or if she's a pregnant lady, she will be on erythromycin. Keeping in mind that when we are stepping to the second choice, we have to make sure that the patient has continued his comoxiclav or clarithromycin treatment first. In children, it doesn't make a big difference. It's still the same. It's still Comox and the same allergies in mind, but it is only the different doses, and it's always for 5 days, if you can see. Okay. Chronic rhinosinusitis, I'm not going to go through that thoroughly. It is just the same alarming symptoms for having polyps and following the algorithm to see where is the patient, which type of polyps we are looking for. Is it the allergic type or the non-allergic type? Has the patient had any oral corticosteroids or only long-term antibiotics? Are we considering sinus surgery? And that's after 12 weeks of non-improving symptoms for polyps. What are we going to do, and what are we aiming for the pathology? Is it the eosinophils, the Charcot-Leydig crystals in the fungal patients? And again, we are going to give the patient some steroids orally and nasally after surgery. So in that protocol, we are just knowing where's our patient with the timelines of 10 days first, 6 to 12 weeks, and pre and post-op. In this table, which is again from Scott Brown, there could be other diseases which are causing the rhinosinusitis, and that will affect our management and the progression of the disease. If it is something behind with some cystic fibrosis, so we can ask for this gene mutation. If it is ciliary dyskinesia, there might be some mucociliary clearance. For example, if the patient is infectious, having HIV, sarcoidosis, TB, GPA, all of these things with clinical history and examination, we will be asking for the specific type of tests for each one of them. So that's just to quickly go through that there are loads of diseases which might be at the background of chronic rhinosinusitis. It's not just an infection. It is not just like a viral infection. There could be something systematic going on. Our medical management will be one of those things, or even altogether, intranasal corticosteroids, which is the main thing which we would advise of. The short courses of systemic corticosteroids, and it is only for a very short term for not having any side effects. Antihistaminics if the patient is allergic, or leukotriene inhibitors if the patient is asthmatic. So when we are prescribing something for patients with polyps, we'll be thinking of one of these 4 things. And immunology, there has been new modalities of treatment which are called monoclonal antibodies. These are the 3 main medications: omalizumab, dupilumab, and mepolizumab. They are all aimed to target the interleukins 4, 5, and 13, just to be specifically targeting the polyps and reduce the size. It has been getting significant improvement in the US, but here in the NHS, because of the cost benefit and the burden of the cost effectiveness on the NHS, it hasn't been running on our system. But would any patient have these monoclonal antibodies? I don't think so. It should be the bilateral nasal polyps with at least 3 of those criteria, which is type 2 inflammation, which we will know with the eosinophilic count. We will be asking for it on the blood tests, or the systemic corticosteroids, and having significant impact on quality of life with this questionnaire. I'm gonna describe it later on. significant loss of smell, and comorbid asthma. So whenever we are diagnosing a patient, we are just gonna understand, is he having one of these things in order to prescribe antibodies or not? If we are suspecting a bacterial sinusitis, so those 4 symptoms will be quite helpful. If the patient is having nasal purulence or a post-nasal purulent discharge or a high fever more than 39 or a very high ESR, those are the things which will make us prescribe antibiotics. If it is not, so we would think of a viral infection, just keep the patient on symptomatic treatment, not prescribing any antibiotics. And the delivery of the steroids is very important for having a device which is having a positive pressure and a high volume irrigation. And similarly, if we are prescribing oral corticosteroids, this will help significantly with antibiotic prescription. And this has been on a meta-analysis done recently in order to know, are we prescribing oral steroids for a patient with acute bacterial sinusitis? Yes, we are, because this will lessen the period of disease and the symptoms to be controlled. As we said, if you are going to give any patient an oral steroid, please make sure that it's only for 2 to 4 weeks. And there is no benefit of putting the patient on a very long-term, more than 12 weeks course, because down the line, it's not going to improve the symptoms. It's just still the same. And it is the same for macrolides as well, which are the clarithromycin and stuff. There is this ongoing trial, which is called the macro trial. We are still aiming to deliver clarithromycin antibiotics within the guidance of treating polyps, but we're still recruiting patients, and it's up to, I think, 600 patients to be enrolled. They have reached now 450 over 17 trusts over the UK. So hopefully, with time, we will have a good guidance on whether or not to use clarithromycin with polyps. This is the ideal technique to advise your patient with in order to irrigate the nose, because this is quite important to clean the sinuses, clean the cilia, and push the crusts and irrigate the polyps properly. So if the patient is having this, as we said, high pressure, volume, just to squirt half of the bottle into one nostril, and this is over the sink, just to go through the nasopharynx. And if we are giving nasal drops or steroids, this would be ideal to reach the sinuses properly, just not to go through the floor and be jumping into the nasopharynx before reaching the polyps. There are some guidance on the Baby Johnson shampoo, which will help with the biofilm and the saline irrigation as well. So keep in mind using those stuff in a patient who is having chronic polyps, not acute, but just like a chronic sinusitis, in order to avoid complications. And this is the SNOT 22 questionnaire, and the maximum score, I think, will be around 40. If the patient has had his course of antibiotics, saline douches, steroids, please advise with this score. In your follow-up, you will understand if the patient is getting worse, getting better, where are we from the treatment, shall we step him down from oral steroids or not, shall we think of surgery or not. So this is a very good scoring system for polyps and sinusitis improvement. The second part of the lecture is the complicated sinusitis. I think the definition of complicated sinusitis is when the patient is having spread of infection, and it is quite common in children and adolescents because of the thin lamina papyracea and the porous bony septa and open suture lines, larger vascular foramina. So we would expect that in children and adolescents more than adults because of these factors. And the routes of spread will be the lamina papyracea to the eye and the orbit. It could be the valvus, diploid veins to the dura and the brain. The frontal sinus will make us see a Potts-Moffitt tumor, which is a very small swelling up above the eyebrow. Ethmoids will be the main gateway to the orbits and causing eyelid swelling. The sphenoids are the root for meningitis and cavernous sinus thrombosis, and the maxillary, although it's quite rare for the maxillary to cause some symptoms because of the thick wall all around, but if this happens, it will be causing some cheek swelling. So I think our main sinuses to be causing some complications will be the frontal and the ethmoids. And we can classify the complications into orbital, intracranial, or bony, or chronic. chronic being the least common to happen, because aiming for a mucocele or a piocele, this will take very long time for some mucocele to be enlarging and compressing the air cells around. And the orbital is the most common, as we said, for the thin laminar hyperplasia. Preceptor cellulitis is affecting 50% of the complicated patients. Going deeper means that the prevalence is less, maybe because we are treating patients or we are catching them earlier, but still the preorbital cellulitis is the most common thing to happen. In the intracranial compartment, it would be the subdural empyema. It's not going still into the brain, but if this is happening, we will have specific symptoms to treat, and we will ask for the neurosurgeons to be involved. 60 to 85% of orbital cellulitis patients are secondary to sinusitis, and maybe that's why we are getting loads of calls from our ophthalmology team. They are right, it's always the nose which could be affecting it. However, we just they would need to exclude the dacryocystitis, which is the infection of the lacrimal system, and facial infection. And this is the Chandler classification. That's how we can grade our orbital cellulitis and orbital complications of sinusitis. If we are still in front of the preorbital septum, this is the most common type, and we call it preseptal cellulitis. If it has breached this septum, so it is an orbital cellulitis. If there is a pus collecting just lateral to the lamina hyperplasia, it will be a subperiosteal abscess, and this will be quite the CT will be very handy here in order to show it on the contrast-based enhanced CT scan. And the orbital abscess is the whole cavity, or the globe is full of pus, and cavernous sinus thrombosis is the most serious complication, and quite not rare, but once we reach that point, we will be aiming for more aggressive treatment. This is the same table explaining where are we from the anatomy and how can we explain that. It's quite good to read the CT and the MRI report, because it will go through every bit of anatomy to explain which stage are we on from the complications. Okay, if we are suspecting complicated sinusitis, what we are gonna do is to scope the patients and use the scoring which we asked for, the polyps, the crustation, the edema. We are gonna assess the eye, or our ophthalmology oculoplastics team will gonna describe these points and let us know if the patient is having affected vision, affected color, or neurological examination if the patient is having some impairment. The imaging, if the CT scan or the MRI scan is recommended, and just keep in mind that the CT scan might miss up to 50% of intracranial complications. So if you are really having a low threshold of a central complication, please ask for an MRI scan. Blood cultures and nasal swabs are quite important in delivering the microbiology MDT decision about which antibiotic to continue on. And this algorithm is on the ENT UK website. It's really important to understand if the patient is having only preceptor cellulitis. So we can still discharge the patient. We can give them only oral comoxiclav or clindamycin if he's allergic to penicillin, and considering safety netting the patient and advising him if there is worsening of symptoms, please come back within 48 hours. This is quite important, and this is where the 50% of our patients lie on. We are going to depend on the ophthalmology team's referral, what they have thought about the vision, the color, the pupillary reflex, and if we clinically are still seeing very small polyp or some mucus discharge which can be dealt with oral antibiotics, we can discharge the patient. We don't have to admit them. Indications for admissions will be a patient who is immunocompromised, pyrexia, non-improvement on oral antibiotics, or less than 12 months old, which is an infant. This is quite important to admit this patient and put them on the IV antibiotics. The medical management will be tazocine, the peds will be comoxiclav, and keeping in mind for sure if we're going to bring the patients for steroids or not. Indications for imaging will be definitely something central, something affecting the eye, or neurological assessment, or failure of improving symptoms within 48 hours. The CT scan will be with contrast in order to show us the brain, the sinuses, and if there's any liquefaction. And if there's any orbital collection, definitely we are gonna aim for drainage. And it will be a joint care between the ophthalmology, oculoplastics, and ENT. So it is about understanding where is the patient from this protocol. Can we discharge him on oral antibiotics? Can we admit him on IV antibiotics? Can we be more aggressive in offering some CT scan or thinking of drainage? It depends on where are we from this protocol. Orbital cellulitis, it could be still managed by antibiotics and nasal decongestants, although it's quite inconclusive on evidence that decongestants would help, but we are still offering some xylometazoline or nasal drops like bednosol. And indications for orbital separation will be crystal clear, evidence of collection on CT scan or lack of improvement after 48 hours of IV antibiotics. That's the decision to be made in the ward when we are seeing our patients and asking for our questionnaire, the symptoms, any central affection, headache, blurred vision, and etc. There has been some studies describing, okay, we have been having a very low threshold in children. Would we urge for a child who is having some orbital cellulitis to be surgically drained with endoscopy? Actually, no. We would still hold fire if the collection is just about 0.5 to 1 milliliter in diameter and it is medially located, there is no systemic improvement or visual affection. We are still in keep with the plan of IV antibiotics and withholding drainage. As this very small volume medially placed, it will still drain through the lamina preparation to the nose if we give the proper treatment. It's all about the cavernous sinus thrombosis. This is like our big fear. If the patient is having the central disease affected third, fourth, and sixth cranial nerves, having very bad headaches, blurred vision, this is definitely a patient who will need at least 2 weeks of antibiotics. And anticoagulation is controversial. Sometimes we would ask for the hematology team if we are having a cavernous sinus thrombosis, would they advise of anticoagulants or not? Actually, there are debates. Whoever is with are saying that it is affecting the thrombus by an anti-inflammatory way. Others who are avoiding it are saying that it will increase the bleeding, and the thrombus is around the bacteria anyway, so it's not going to spread. So it depends on some team's preference and consultant's decision about whether to give anticoagulants or not. The intracranial complications, it depends on the imaging, if it is a subdural or an extradural. I'm not going to be going so far with this intracranial thing, but it's all about seeing the scan. Where are we from the dura? Are we breaching the dura? Are we into the brain, cerebrum? Is it affecting those cells? What will be the plan for neurosurgeons? Are they offering a craniotomy? Are they conservatively managing the patient? So that's when we will ask for their advice. The bony complications, it's only the Potts-Puffy tumor, which is actually, this lady had a Potts-Puffy tumor. It has been breaching the frontal table of the sinus, and that's when we are asking for not only ENT, but the neurosurgeons to be involved if there's any cerebral affection. The good thing is, if we are having a Potts-Puffy tumor, sometimes we can only drain it externally, and we wouldn't advise of a endoscopic sinus surgery till everything is controlled in order to give it some way of drainage in the future. So as if we are dealing with a very local abscess, we can do some trephination here and deal with an abscess isolated from the whole frontal drainage intranasally, which we can do on an elective basis. Chronic complications, as we said, it's not as common. Mucocele, it is again to be picked up on a CT scan, or it might be causing some compression and headache. I'm gonna share a video about a draft 3. This is not mine, actually. It's one of my colleagues back in Egypt. He's one of the really good surgeons of sinus surgery. This has been like just to show some anatomy in this video, actually. This patient has had some polypectomy pre-hand. This was like the third time of polyps. You can see here that the ethmoids are removed already. Here, they are just trying to open the maxillary sinus with some mucosal bands and bleeding of active infection all around. They are still lateral to the middle terminate. Understanding the anatomy is quite important here. These are the polyps around the skull base. Here we are aiming for the posterior ethmoids and the sphenoids. The more you go at the back, we are still seeing that we are still having some crustaceans and polyps. In that way, we are just medializing the middle terminate in order to show some anatomy, and feeling the skull base is really important in order not to breach it or have a CSF lake. Using a navigator is important in those types of patients in order to know where are we from the skull base, the orbit, have we breached the dura, and making mucosal cuts as flaps will help us in draining and going for a draft-free, which is from the frontal to frontal sinus and taking the whole septum out, and this will be the end of a draft-free, which is the septum being resected, the middle terminates being resected, and we are only on the lamina papyracea on both sides with the two frontal sinuses connected all together. As you can see here, this is the frontal sinus all the way through. So this is really important to connect things all together for the patient not to have any obstructed drainage. And that's when we are aiming for a complete patent sinuses all the way through bilaterally. These are some links if you would like to have some time to understand the guidance and reference behind the things we advise of, which is managing an abscess in a child who is having acute bacterial sinusitis, or steroids and orbital cellulitis. How often can we use that? The macro trial and the EPOS summary. There is a smaller edition of the EPOS, which is just like few 20 to 40 papers, I think, which I took all the reference from. This is just like a small scenario we can discuss. For example, you have seen a man who is having some red swelling on the upper eyelid, and he's able to be opening his eye, but there is no thermoplasia or change in acuity. He's systemically well with raised inflammatory markers. How would you manage him? Would you give him some antibiotics, discharge on oral antibiotics, and review in 24 to 48 hours, offering a CT scan, steroids, or colophthalmology? What do you think? Good learners. So as we see here, the eye is normal and everything is fine. We can still discharge the patient. What about this? It is just a question about the pathophysiology. It's a 15-year-old boy who is having left-sided facial pain for 10 days and having upper respiratory tract infection, some edema in the eyelids, and an antral washout showed some pus and aspirate from the maxillary sinus. Which would be the most common bacteria affecting this type of patients? Is it Streptococcus pneumonia, MRSA, Pseudomonas, or Staph aureus? Amazing. Good. I am done now. Just finished this, just a disclaimer about how is those slides one of the contents of our teaching program. And thank you everybody for attendance, and I'm happy to take any questions if there is any.
The scoring system that you put on the slide, do you use that at all to decide if you are to admit someone? For example, if this scores high enough, you get admitted, or?
You mean this one?
Yeah.
Yeah, this is only for, I would use that in clinic if I'm seeing a patient who is having chronic polyps and deciding about whether to give him another course of steroids or decide about surgery after 12 weeks of non-improvement on whatever we have gone through. So it is basically, if you had a read of it, it is going through the nasal symptoms, the ear symptoms related, the central symptoms, and the quality of life. So in that way, you are just gonna use it in your history taking. After you finish with the patient, please have a seat here. This will only take 2 minutes. Try to give me an impression of where are we from our treatment. So it's not about admission. Admission will be more of an acute case coming into your A&E department, more of those type of things. You are just trying to ask for the vision. You are trying to ask about simple questions of oral antibiotics. How many days has he had? You are trying to ask about allergies, taking some bloods as CRP, doing some vital signs. So I think for admission, this would be your guidance. But for changing treatment or considering surgery, it will be the scoring plus several factors, which is the CT scan, imaging, and quality of life for sure. It's a good question, actually, because if you are thinking of something, if a patient is not improving, so you will be going through those types of disease. Just keep in mind, you are thinking broadly. The patient might be having something at the background, which is a neoplasm, metabolism, congenital problems. So all of these things, you will be asking for those specific. That's what the rhinology would do. The rhinologist would do. They would just ask for those types of tests, although it is not 100% helping. It could be still quite specific, but it's not sensitive. So, but at least it will guide you through why is the patient not improving. So, for example, you will ask for a biopsy if one of those came back as positive. If you're thinking of a GPA, it came back as C ANCA positive, so you'll take a biopsy. If you're thinking of a malignancy, sure, you will offer some MRI scan, CT chest for staging, and etc. So, yeah. Anything else?
We mentioned the baby Johnson shampoo
Mhm.
for the biofilm. Was that specific to the child?
No, just like the shampoo. There was some studies on the EPOS guidelines describing how it will be helping in just detaching the biofilm attached to the polyps and delivering more steroids and treatment for it. So I haven't used it in one of my patients, but just this.
Would you advise that for a patient in clinic?
If the patient is having some resistance or not improving on on antibiotics or nasal steroids, we might advise of just douching in the same way as this maneuver. So it's quite important to use those bottles because it's giving really good pressure. It's delivered into the whole polyps and to the whole sinuses. Yeah.
You know, the Lund Kennedy and the Lund McKay scores, are those used to guide
Yeah. So
surgery and
our,
stuff like that? Or?
yeah, it's about, so this is like the clinical aspect of the scoring. So if you are in clinic and you have senior patients, you will ask them to fill the score, which is the SNOT score here.
Mhm.
And from your side in clinic, you are gonna use your, where is it? Your scores here as for the endoscopy and the radiology. And I think most of our radiologists here are using, if you have a read of their letters, they will describe the Lund Kennedy scoring and the Lund McKay.
And if they're high?
If they're high, they will offer surgery. If it is not, so they will just keep on same modalities of treatment. So yeah, it's good to relate both things together and advice of things. Again, this is not related to the complicated cases. It's just like to understand where are we from the patients, because these types of patients are suffering for years and years, and they will have revision surgeries as well. So if I'm a consultant who has done a surgery for a patient as endoscopic sinus surgery, when am I gonna give the patient another surgery? It depends on those inputs.
And when are you ordering a CT? Like, I know at the beginning you kind of said this is the thing that we would do, and then you mentioned CT for sinuses, but would that be someone that has loads of symptoms and?
You mean for a CT scan?
Yeah.
One of the reasons is if it is unilateral, I would think of a cancer or a malignant polyp or a vascular one. So I would just like to exclude the main concerns of having something malignant. So the CT scan is quite helpful. Or if we are thinking surgically, I wouldn't, if I'm in clinic and I can clinically see allergic polyps, the patient is asthmatic and he's having some allergy to any of that. So yeah, I wouldn't think of a CT scan now because actually we're not aiming for surgery. And the CT scan is really nice in describing the bony framework of the sinuses. So I would go for it if we're thinking of surgery within 3 months' time. A surgeon wouldn't prefer having a very old CT scan when they are operating, and that's what's happening with the waiting lists. If the patient is having like a 3 years old CT scan, that's not appropriate actually. There might have been some complications happening, some breaching of a bony bit, which will affect the technique. So CT scan is preferred to be done as a fresh investigation.
Thank you.
Thank you so much. Any other questions? Any questions from the audience, guys? Nobody asked.
Okay, good.
Okay, look.
Fine.
Thank you, everyone.